My name is Pamela Merritt, and I am Executive Director of Medical Students for Choice. For 30 years, Medical Students for Choice has worked to ensure that medical students and trainees are educated about all aspects of reproductive health care, including abortion. We are a global nonprofit with 300 chapters in 30 countries. Last year, the United States Supreme Court struck down the landmark 1973 Roe v. Wade ruling that established a constitutional right to abortion in the U.S. Since the court's ruling last year in Dobbs v. Jackson Women's Health Organization, both medical education and the profession of medicine have suffered significant disruption and harm. Tonight, you will hear from physicians how the Dobbs ruling has changed their access to medical training and their professional plans, and why regressive anti-abortion bans will have negative consequences for the profession of medicine. I'm going to introduce all of the speakers, and then they will speak, obviously, individually. Our first speaker tonight will be Dr. Lynn Van Wang. Is a board-certified family physician. She attended Albert Einstein College of Medicine in the Bronx, New York, and received her master's in public health at Columbia University in New York City. She completed her residency in family and social medicine in 2011 and family planning fellowship in 2013 at Montefiore Medical Center, Albert Einstein College of Medicine. Dr. Wang uses her perspective as a queer person, an immigrant and child of immigrants from Taiwan, and as a woman of color to provide individualized, liberatory, culturally humble, and trauma-informed care. In addition to queer health, her professional interests include racial and reproductive justice and adolescent health. Our next speaker will be Dr. Chelsea Daniels, who is a third-year family medicine resident at the University of North Carolina in Chapel Hill. She received her undergraduate degree from the University of California, Berkeley, and her medical degree from the State University of New York Downstate College of Medicine in Brooklyn. She currently serves as the Reproductive Health Access Project Liaison to the North Carolina Academy of Family Physicians. After she finishes residency this summer, she will start a full-time position in abortion care and reproductive health care at Planned Parenthood affiliate in Miami. And hopefully we're waiting for our final speaker to join us. So I'm going to go ahead and get started with by introducing and handing it over to Dr. Wang.
Hi, everyone. Thank you so much. So again, I'm Dr. Lynn Fan Wei. My pronouns are she and hers. And I've actually came home today after traveling within Pennsylvania to provide abortion care. And so my cat has been waiting so patiently for me all day and just wants some snuggles right now. So I hope you all are okay with cats. But I'm in the Philadelphia area, and I am co-founder and member of Centers Health, which I will tell you about in a little bit. But I came to abortion care really through my love of primary care and wanting to be a family medicine provider. I went into family medicine just really loving everyone that I saw. So from babies to elderly people. And I really just wanted to take care of people in all steps of their life. And when it came to reproductive health, I also really wanted to just take care of people when it came to their pregnancy decisions and whatever they decided about their pregnancy. So as I was doing my training, I really saw abortion as part of primary care. And especially because, the majority of abortions do happen in the first trimester. They're really safe, easy, straightforward, either by taking medications or having a procedure that can be done safely in a primary care office. And I did find that my patients did want to see me for their abortion care. Patients get really attached to their primary care provider and really don't want to have to go somewhere else for their care. And then I moved to Pennsylvania. So I did all my training in New York and I moved to Pennsylvania where the restrictions were very different. And so all of a sudden I was working in a primary care clinic where I couldn't provide abortion care anymore because of the restrictions that we had. And I was forced to really refer my patients out to have their abortion care done in centers that were much more regulated. And so I did, so for a while, I did some primary care. I was also working at clinics that provided mainly abortion services. And I did that for a while. And then the Dobbs decision came. And, at that time, Pennsylvania laws weren't impacted by the restrictions that happened with Dobbs. But the worry was more about, well, what happens now, right? And Pennsylvania is a state where with each election, you never know what's going to happen with abortion care. Dobbs happened, and then we were thinking, my partner and I were thinking, so this election is coming up. How do we respond to that? Do we, right, with this next election, it's entirely possible that we would have a legislature and a governor who would restrict abortion access. So does that mean then I'm out of a job, right? That I can't provide abortion care in Pennsylvania anymore? And if I can't provide abortion care, then do I just do primary care? What do I do? And so much of my training, my life, my values, my morals, affected me to the point where like abortion is so strongly important for me to be able to provide as a family physician. And then the other concern that I had, that we both had, was that what does this mean when patients come in and see me who are out of state? Right. And especially, and then we were seeing that states like Texas and other states were beginning to criminalize abortion care. So what does that mean for me as a provider if I'm taking care of a patient who's in front of me who has a need? I was, and like for me, like I'm very much about like doing my job, right? Like whoever comes and sees me, I provide that care for them. But my partner said, you have to realize that you are an Asian American immigrant. And right. And then at the same time, there was all this like anti-China, right? Like COVID stuff happening. And also at one of the clinics where I go to, the protesters were constantly yelling at me to like go back to China, to like not kill American babies, like to kill Chinese babies instead. Right. And so he said, like, you have to really think about all of this like racism and xenophobia that would affect you as an Asian American provider. And then also, like, I'm Black, and for you with a Black partner, you have to think about like how, like that extra layer of racism on top of that. And so at that point, we were thinking about, okay, so then does this, like, do we move out of state then, right? Do we go to New Jersey or New York or like one of the other bordering states near us? And we just really struggled with that decision because it wasn't a decision that we wanted to make, right? We were really forced into it because of politics. So I would say like during that time, it was really the community of other physicians of color and in particular family physicians of color that really helped me have hope and have energy to move forward and have the confidence to stay in Philadelphia. And so in particular, I want to talk about our Center's Health, which stands for Collective Energy for Nurturing Training and Reproductive and Sexual Health. So we are a collective of radical family physicians of color providing abortion, reproductive, and sexual health care across the U.S. And our mission is to liberate abortion training and care from the machinations of white supremacy. And we are creating a space that centers the love, healing, mentorship, and sponsorship of new Black and Brown family physicians that provide abortion care. And it's really through my, physician colleagues, especially my physician colleagues of color, that have allowed me to continue to do the work in the way that I want to. Thank you.
Thank you so much, Dr. Lin Fan. So our next speaker is Dr. Chelsea Daniels.
Hi, everyone. My name is Dr. Chelsea Daniels, and thank you all for being here and to Pamela for organizing and inviting. I am a third-year family medicine resident at UNC in Chapel Hill. I'm not originally a Southerner. As my bio alluded to, I grew up in California and then spent many years in New York City and then made it down to the Southeast for residency. So I think kind of similar to Dr. Wang, it was a bit of a culture shock coming to a place with much more restrictive laws, especially at such a pivotal point in my medical career and in my medical training. And that is mainly what I would like to talk about, just kind of the challenges that I have faced as someone who wants to do abortion with my life, getting that training in a state as restrictive as North Carolina. So I first started residency knowing I wanted to pursue abortion and was able to very fully immerse myself in local training sites in North Carolina. But once the Dobbs decision came down and laws became more restrictive in surrounding states and other providers suddenly needed to keep their skills up or wanted to gain skills, it meant that this very limited amount of training time at a limited amount of clinics in the area suddenly became really a hot commodity. And so I lost a lot of my training access as a senior resident. And so what that meant is that I had to cross state lines in order to get training, which was a great experience. And I went up to Chicago, and it was obviously fun to live in another place and all of those things, but it was also really expensive and just not something that is imaginable to do for any other part of residency. If you told an internal medicine resident that they had to go up to Chicago in order to learn how to place central lines or something, it would seem just absolutely unimaginable. And so the fact that I had to cross state lines and spend all of this money in order to get this training similarly felt unimaginable. And then for me, I always knew that I wanted to do abortion care in my career, and I've secured a full-time family planning and abortion care job when I finished residency in just a few short weeks, but who's counting? But I am moving down to Florida, where the laws have taken a real change since I signed my contract. And I think that I really can't overstate the amount of anxiety and uncertainty that I and other Floridians, providers, and patients feel. And Florida is obviously a stand-in for any of the restrictive states under these impositions. But as a patient, you have no idea when is the 6-week ban coming down? When will my rights be curtailed? And as a provider, I have no idea what my job will look like because I have no idea what I will legally be able to do. And so to that end, I obtained a travel abortion contract position in Virginia. So I'll be traveling from South Florida to Virginia twice a month in order to provide care. Which is, kind of the length that I feel is necessary and important for me and my goals, but it is certainly a burden to travel so far and a burden that providers and patients who are traveling far and even farther shouldn't have to face. And so I think that Dobbs and just restrictive laws in general, the impacts that it has had on the medical field in general, not to mention patients' access, really can't be overstated in this case. Thank you.
Thank you so much, Dr. Daniels. So our final speaker is Dr. Chantel Tape, and she is a family physician practicing primary care and reproductive health in Pennsylvania. She is passionate about reproductive justice, safe, accessible, and free abortion and contraception, and LGBTQ care. When she is not in clinic, you can find her searching for the best donut in every new city she visits or scouring a used bookstore for out-of-print treasures. Welcome, Dr. Tape.
Thank you so much, Pamela, and thank you everyone for being here. Can you hear me okay?
Yes.
Great. So again, my name is Dr. Tape. I am also a third-year resident. I'm also graduating in the next week and a half. I currently train and practice in Pennsylvania, although I am from New England originally. And I also a little bit to some of the uncertainties that Dr. Daniel sort of mentioned. For myself, I also decided well before I went to medical school that I wanted to be an abortion provider. I had a kind of a circuitous path to medicine. I had about almost 8 years in between when I finished college and when I started medical school. And during that time period, I was fortunate to work in an abortion clinic, mainly helping folks secure financial assistance to pay for abortions. I was at that time living and working in one of the many states where Medicaid was not able to be used to cover abortion procedures. And so I was mainly taking care of low-income people who didn't have access to abortion care and were really struggling to exercise their reproductive rights because of cost. And that experience of working in a clinic was really a game changer for me. It kind of changed the trajectory of the rest of my career and my life in many ways, because this work was so personally meaningful and felt so close to my heart that it was a big driver of my decision to go to medical school. So I had to go back to school, do a post-bac, apply to medical school, which I did. And I did all of that with the expectation that I would provide abortions. And I also, believe in primary care, and that's part of why I chose family medicine, is to sort of keep that integration of reproductive and sexual health care within primary care. And I think just the experience of being in my training when Dobbs was decided really shook up a lot of my future plans. I was the last person in my residency class to get a job because it just was, it felt like every day, every week, there was another abortion ban, another state that I had to think about, is this a place that I could consider training or practicing in the future? I currently live in Pennsylvania, which is a state where abortion is still legal for now, but very much hinges on who are the people in positions of power, whether that continues to be the case. And I will be continuing to practice in Pennsylvania as a primary care doctor and doing some reproductive health as well. But I will also be traveling out of state to provide abortions. I will be traveling to the Midwest to a clinic that is primarily serving folks who are coming from abortion ban states. And it was really hard, I think, to reach a point in my training where I was really starting to make decisions about my future and what kind of practice I want to be doing, and to not be sure if I would legally be able to provide that care. I also left the state of Pennsylvania to do some abortion training. I traveled out to the Midwest during residency to train, which was really hard to fit into a residency schedule, as Dr. Daniels alluded to. And I think sort of part of the dynamic for me as well is thinking about who gets access to this kind of training. And I think particularly for physicians who come from low-income backgrounds, for trainees of color, there are a lot of additional barriers to being able to access this training. It's often not standardized as part of our med school and residency training, even though it should be. And I myself, when I was looking for abortion training opportunities outside of my residency program, I encountered clinics that would say, yeah, we would be happy to train you, but we can't afford to pay you anything. And we would need you to fly out to this part of the country and be here potentially for weeks or months to train without any compensation, which I think reflects a lot of different things. I think it reflects the challenges that many clinics are facing just to be able to keep their doors open, but it also creates an additional barrier for physicians of color who may not have the same amount of resources to be able to access this training. And so I feel really fortunate to have found supportive mentors in this work, particularly through Centers Health, as Dr. Wang spoke of. And I'm really excited to be able to continue doing the things that I love, to continue providing primary care, to continue providing abortion care and sexual and reproductive health care. But it's even challenging thinking about my future to know that I'm going to be, traveling out of state once a month, which means I organized my entire, my closer to full-time job was pretty much entirely arranged around my ability to travel outside of the state to provide abortion care, which was important to me to do that. But I don't think everybody is able to make those kind of adjustments, and it's been really hard. As a person who has a significant other, we've sort of both been planning our lives around this aspect of my work and my training, which has been a pretty significant challenge. And I think it's important, we know that these bans are affecting our patients in ways that we're only beginning to discover, but I think it's also important to be having that parallel conversation about what this means for trainees, and particularly what this means for the next generation of sexual and reproductive health providers, to make sure that we're training people to be able to continue doing this work. Thank you all, I appreciate it.
Thank you so much. So at this point, it should be clear, having heard from our excellent speakers, that there has been a devastating impact after the Dobbs ruling. And also there is lingering confusion about exactly what the future holds. So the profession of medicine is really being threatened as this goes on and on. At this time, I'm going to unmute our speakers, and then we have a manageable amount of attendees. So I'm going to ask that folks go and you can either drop a question in the chat, or you can raise your hand as a reaction, and I will unmute you if you want to ask questions. Okay, and please say, I'm going to unmute you, and please say which, what your affiliation is to.
Hey all, this is Sarah Hutchinson. I'm with the Texas Observer. I had a question for, I guess, primarily Dr. Wang and you, but also maybe Dr. Tape. I wanted to know for folks that are family physicians, if you're providing primarily medication abortions or surgical abortions. And I wanted to hear your thoughts on, if you are primarily providing medical abortions, how, I'm sure you're watching the mifepristone case and how that might impact your practice as well.
Is that for Dr. Wang?
Yeah, I think you can both answer.
Yeah.
All of you can answer if you'd like.
Yeah, I can get us started. So I provide both medication and procedural abortions. And I just wanted to make a comment that we are, as a field, trying to move away from using the term surgical when referring to procedural abortions, because surgery involves like cutting, right? And involves like it requires sedation and being in an operating room. And abortions don't have any of those requirements. And then also for our patients, when we talk about surgeries, that's also what they imagine. So I often will have patients think that I'm cutting them open using sharp knives without sedation. I'm like, no, that's not what's happening at all. And so so we as a field are referring to them as procedural abortions. And just to kind of put it into context, the techniques and the overall way that we provide procedural abortions are very similar to IUD insertions, or to biopsies for uterine cancer. And these are all done in an outpatient setting without any type of sedation. So I just wanted to make that little comment. But yeah, I am trained in both. And I also wanted to just uplift our nurse practitioner and physician assistant colleagues who also have the credentialing in the background to be able to provide both medication and procedural abortions. Because it is like very, very straightforward and very low risk and doesn't require extensive training. And I think there was another piece to your question too. I think the mifepristone ban. And so we are watching that very carefully. And I think for us, what is so hard is that we know what is right based on our experience and what the research shows us. But then we suddenly are in a moment where we have to become lawyers, and then also have to think about how do we interpret these poorly written laws in our medical practice, right? And this is like nothing that we were ever trained for. And so in terms of that, I think for me personally, I think I am just really bewildered and confused. And also, I think the other piece is that it takes a lot of money in order to get a new medical indication approved for a medication. And so you can have all this research, right? Showing, okay, let's say, like, I'm trying to like think of an example. So let's say like misoprostol, which is one of the pills which was originally approved for treatment of ulcers, right? And right now that's the indication is for treatment of ulcers, but we use it. There's like so much research that has shown, it's actually really helpful for treating severe heavy bleeding after childbirth. It is also helpful for abortion, right? So it has all these other uses now, but there is zero medical, it is not approved by the FDA for any of those other purposes. And the reason why is because it takes a lot of money, right, in order to like put together the research and take it to the FDA and say, hey, this medication that's been on the market is now very, very effective for these other reasons. And here's the money that we're paying you in order to like take a look at our research and figure out whether it is safe to put on the market for this new indication. And so often in medicine, we are not, right? Because like we're doctors, we don't have this money. We're not pharmaceutical companies. And so we often will prescribe things off label, right? Without these FDA approved indications for other reasons that are actually very well supported by the research, but it doesn't have the money behind it in order to get approved for something else. And so we're watching this very carefully. I am very concerned. I think that, what we have available right now is very effective. It's very safe. And if mifepristone, if we weren't able to use it, then that means we would be removing something that's very safe and effective as an option for our patients.
Thank you. Dr. Daniels, did you have anything to add?
No, I was just clarifying that the question was for Dr. Wang, sorry.
So we have a question from James Pollard.
Hello, yes. Thank you all for your time. My name is James Pollard. I'm with the Associated Press in South Carolina. I have a question specifically for Dr. Daniels. What conversations are you and your future employer having about what work might look like if Florida's abortion ban takes effect?
Yeah, good question. The conversations are many and extensive. I feel like there was a period of time in the midst of the first kind of wave of actually the mifepristone uncertainty where I was having so many meetings a week with both my Virginia job and my Florida job. So currently a lot hangs in the balance. There was a period of time where because gender affirming care was also under attack and so heavily in Florida, and it still is, but some of the language on the bills have been changed. The thought was that providers were not going to be doing any gender affirming care and abortions for as long as they'll let us. Now that the gender affirming care language has shifted to where MDs are still protected. It's unfortunately PAs and NPs that are not protected, is my understanding of the current bill. That will still be part of my practice. And what the affiliate that I'm working at is attempting to do is kind of shifting focus and kind of taking care of people and their reproductive health from a more global perspective if we're not able to do the same volume of procedures. So that includes management of abnormal bleeding or chronic pelvic pain. I'm going to be trained in vasectomies, which is the sterilization procedure for folks with testicles. I'm going to be trained in a cervical excision procedure that we use for precancerous cells, basically just trying to expect that this ban will come down at some point, and we're going to have to start seeing patients who have other needs.
Thank you. So we do have a question in the chat from, and I apologize if I do not pronounce your name correctly, but from Sandhya Raman. And this is who is with Roll Call. This question is for everyone, and how much, curious about how much the Dobbs decision has changed how tuned in you are into policy developments and abortion litigation as part of your day-to-day training and work. Dr. Daniels, could you take it first?
Yeah, absolutely. When I first read this, my gut reaction was like, wow, tenfold. I mean, I'm not naive enough to think that abortion is not inherently political, but I'm not naive enough to think that it hasn't been made to be political by our legislators. And I think living in a state as restrictive as North Carolina, moving to a state as restrictive as Florida, I have had my finger on the pulse of legislative sessions more than I have ever had in my whole life about anything, I would say. And I think part of that comes from the fact that this is a deeply personal and important matter to me, but it's also my livelihood and my profession. And like Dr. Wang and Dr. Tape have said, I just simply can't imagine a career without abortion. North Carolina, as I'm sure y'all know, just passed a 12-week ban in the last couple of weeks. And so there was a period of time where every day we were going into the House and storming the floor essentially and protesting the bans. And so it's kind of this like level of activism and being aware of what's going on politically has reached fever pitch, I think, for all of us.
Thank you so much. Dr. Wang.
Hi, so advocacy was, and paying attention to politics was always part of my work, like starting in medical school. And I think part of it was that I started medical school during a time when the president of the United States came out very publicly wanting to restrict reproductive health services. And I think that was for the first time I thought, oh, this is a political issue, right? And I have to pay attention to this. And so I think it was from the beginning of my career when I realized that I do need to pay attention to legislation and to think about advocacy. But I think with the Dobbs decision just heightened everything, right? And so before it was kind of, and also my experience in Pennsylvania, right? I had to understand Pennsylvania law in order to provide abortion. And some of it is just I have to make sure that I had the specific sentence in my documentation. And the sentence was not written by anyone with a background in medicine, right? It was written by a policymaker who has no idea what I do in my day-to-day life, but I have to put this in because of a law. So I had that, right? And so I had that experience in Pennsylvania, but now it's constant, right? And it's almost constant vigilism, right? I'm always worried about something even worse that I can't even imagine that might happen that would affect how I can provide care for my patients and really affects their lives and their health in very profound long-term ways.
Thank you so much. Dr. Tape.
Yeah, I mean, I share what's been said. I think I pay attention to the laws that in the state that I live in historically, but never have I paid so much attention to what's happening legally in other parts of the country. And I think it just can't be overstated how much the literal geography has changed in terms of how far our patients are traveling to get procedures. I spent some time training in a clinic in Michigan over the winter, and there were patients coming from Texas to Michigan to get procedures. And so I think just the whole landscape has changed, and it feels like every day there's some new attack and some new sense of our patients being threatened, our work being threatened, our ability to provide the care that we think is meaningful and that we know is right for our patients being threatened. And it's hard even to, react positively when there are small, rays of hope in that. My home state of Rhode Island recently passed a bill for the first time allowing Medicaid to pay for abortion procedures in the state, which was a huge victory and felt really personally meaningful to me as somebody who used to work in a clinic there. But it almost even that excitement was tamped down by just how many ways in which reproductive health care has been attacked. In my home state, there's only one clinic. And so it was exciting to hear this news, but we also know that the ability of future providers to keep doing this work is still constantly under threat, whether it be from trap laws that target, the physical space of our clinics, whether it be from which providers get to provide this care. And so I think we're being attacked from a lot of different sides right now. And it's hard to cope with that.
Thank you all so much. Do we have any other questions? Joyce, go. Yes.
Hi, thank you so much for doing this call. I'm with the Washington Post. I missed probably the first 10 minutes of this call, so I apologize if this means that you guys are repeating yourselves in any capacity. But we were curious about how you think the gap in education could affect providing healthcare to communities at large long-term, sort of both on the levels of how many, OBGYNs will want to be practicing in redder states that have either outlawed or restricted abortion rights. And also, long-term, what that means for communities. What are you guys seeing now? And what are your predictions for how this could affect, care to the communities at large?
Thank you for that. Dr. Daniels?
That's a big question. We already are seeing data from medical school graduates applying to residency that where they are applying to residency in both OBGYN and family medicine, because these are the specialties that kind of historically practice abortion, that is being hugely affected based on state restrictions. And then kind of similarly, if you are lucky enough to be in a state where there are not restrictions, the training spaces are limited because the volume is being absorbed. So for example, I'm in North Carolina, which up until quite recently, we were providing abortions up until 20 weeks, and we were the only state in the South doing any abortions. So we had absorbed volume from the whole state patient-wise, but also all of the residency training programs suddenly wanted to train in North Carolina because that was where residents could be trained. So what I think that means for patients is that there is obviously a dearth of providers. So this means that there's a dearth of open patient slots in a given template. So when I think about a day at my clinic in North Carolina, if there's 20 slots open, prior to Dobbs, it would have been, 12 to 15 North Carolinians, a majority North Carolinians. And now I would say that it's less than half North Carolinians. And that's because folks are coming from Alabama and Mississippi, or Kentucky, Indiana, kind of other parts of the Midwest that are adjacent. And while, of course, it's fantastic that these folks are able to get access, it also begs the question of where are the North Carolinians going who can't get access. And then I think similarly, as a now graduating resident going into my attending life, the same kind of questions that are presumably dogging fourth year med students are dogging me, or were dogging me when I was applying for positions as to where can I go out and practice. And what does that look like? These communities that are in the most desperate need of providers are also tend to be the communities with the most restrictive laws. So it's a bit of a catch-22 where the places where providers are needed are the places where providers can't get hired.
Yeah. And I'll add that, before joining MSFC, Medical Students for Choice, I had spent many years working on Black infant and maternal mortality awareness and trying to improve those numbers in my home state of Missouri. And it would be remiss not to point out that what Dr. Daniels said over impacts communities of color, and the United States has the worst pregnancy outcomes in the developed world. And within this country, the states that are most restrictive have some of the most horrendous pregnancy outcome and mortality rates for people of color and Black folks who can experience pregnancy. So, not only are we just deeply concerned for the country as a whole, but one of my greatest fears when the Dobbs decision came down was that we would start to see the kind of numbers that existed pre-Roe. And for my community, those numbers were absolutely horrific, which is one of the reasons why many activists, Black activists, were pushing for access to legal abortion, but also Medicaid coverage for abortion so that people who are economically challenged can access the care. It's a life or death issue for many communities. Dr. Wang, Dr. Tape, did you want to also weigh in?
Yeah, thank you. I'll just thank you for both of your comments. And I'll just add that that we have to be concerned about all physicians, right? And also the other piece is that the United States already does not have enough primary care physicians, and physicians now are talking about, and physicians and trainees are now talking about, if I have the capacity to become pregnant, I want to be in a state where I can get the care that I need. And I want to be in a state where I can be safe getting that care. And so it's not just about physicians being able to practice, but it's about physicians themselves as patients needing reproductive health care. And then I also want to say that abortion is also, right, restrictions to abortion, because abortion, right, and again, it has to do with people who are not in medicine trying to define what we can and cannot do in medicine, is that we're right, and we're already seeing this in Texas and in other states, is that it's now, because the laws are so vaguely and poorly written, that abortion also applies to miscarriage management, to ectopic pregnancy, to high-risk pregnancy situations where the life of the pregnant person is threatened, but they are not imminently dying. And so all of these laws impact people and physicians who may not be abortion providers, but they do provide other types of care that involve pregnant people. And then just the last piece that I want to say, and was to add on to the piece about Black maternal mortality, is that providers of color, the research has shown that they are much more likely to work in areas that are underserved, and much more likely to want to provide in the communities that they come from. And so when we think about, right, these restrictions, and for providers of color, it disproportionately impacts communities of color, but also providers of color.
Thank you so much. Dr. Tape?
Yeah, I mean, I second everything that everyone else had said. The only thing that I would add is that I chose my residency pre-Dobbs, and I really only interviewed at residency programs that had integrated abortion training and integrated LGBTQ care. And so I think we can pretty easily extrapolate that this really is going to change the landscape of where people choose to train and choose to practice and live, exactly as Dr. Wang had alluded to.
Yes, definitely. So we do have a question in the chat from James Pollard with the Associated Press, asking if you could speak to your decision to stay in states where, at the least, the same level of legal access to abortion is not guaranteed going forward. What made you want to continue practicing in Pennsylvania, where political control seesaws, or move to Florida, where Republicans are moving to restrict abortion? So we'll start with Dr. Daniels.
This was a very challenging personal decision for me to make. Dr. Tape kind of mentioned it when she was choosing jobs, that there was just so much that goes into play when you're looking for a career in abortion care. And ultimately, I kind of made the decision of, I knew that I wanted to either stay in North Carolina or continue to work in a similarly kind of underserved catchment area, that it would be, obviously I felt this kind of pull to the coasts because that was where I was most comfortable. And that's where I had lived prior to North Carolina. And there's certainly a personal safety that comes with that, as well as job safety. But I feel like, especially at this stage in my career, I just wouldn't have gotten the kind of satisfaction that I'm looking for. And I wanted to be in a place and kind of fight the fight in a place where the fight is happening. So I was ultimately deciding between a job in Miami and a job in Wichita, Kansas. And I chose Miami for many reasons that I won't bore you with. But I think that I see my role as the actual act of providing abortions is a really small sliver of the role of an abortion provider. I think being there for patients, being media facing, being an advocate in the communities, you can do all of that, even if the actual ability to perform abortions is limited. And that kind of work is still very important.
Thank you very much. Dr. Tape.
Yeah, I mean, I think again, it is in some ways a personal decision, but I feel connected to the city that I live in and the patients that I've trained here. And part of medical training for most of us is being uprooted at many different points in our career trajectory. A computer decided where I would go to residency, and it spit out a program in Pennsylvania. And thankfully, I've loved the city that I live in and the patients that I get to take care of here. And so I decided to plant some roots, at least for a while. And it feels meaningful to me to have made that choice and to finally have some control over where I get to practice and be in the country, even if it's a small slice of control.
Thank you so much. Dr. Wang.
Yeah, and I think if you whenever you ask any healthcare provider why they make a decision they made, it's always about their patients. And so I would agree, it's really about my patients. I think since Dobbs and since we've seen our surrounding states have more restrictions, patients have been traveling further within Pennsylvania, because Pennsylvania is a huge state. So they've been traveling further throughout Pennsylvania in order to come to the clinics where I work at. And the need is just so high. And I am just so grateful that I have a job where I can provide the care that I feel is so fulfilling and so important. I do have physician colleagues who are working in other states where abortion has been banned completely and they are not able to provide abortion. And I see how difficult it is for them. And so I'm just so grateful that I can be here and providing this care. And I think ultimately what gives me strength are my other physician colleagues who I feel like we're just in community with each other and really in this together and thinking long about, I think it's really about the future generations and what kind of future we want to see for them. And that's, what keeps me here.
Thank you so much. Do we have any other questions? Seeing none, I think we can wrap the call. I'm going to ask, first of all, I want to thank Dr. Daniels, Tape, and Wang so much for your time tonight and for sharing your personal experience in our post-Dobbs America. I want to thank all of the reporters who were able to show up. We will be sending a recording of this after it is done. And I will just ask that the speakers, the doctors, stay on the call just for a moment. But thank you, everybody else, for joining.